Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is brought to you by apnea. We have chatted with guests previously on the importance of endotyping OSA, but not everyone agrees on its importance or how to determine someone's OSA endotype. Dr. Danny Eckert has studied this for years. He and his colleagues have developed a model to help us with this. He is a sleep and respiratory physiologist in Australia and has been actively involved in human sleep and respiratory physiology since 2001. He is the 2023 recipient of the Gold Medal in Sleep Disordered Breathing Award from the European Respiratory Society and joins us today from Australia. Welcome. Thanks for joining us.
Thanks so much. Great to be here.
So, why should we care about endotyping? Does this change our management of the patient?
Well, that's certainly the goal. And the reason we should care is, I would argue that our current model of care is really failing too many patients. It's cumbersome, it's time-consuming, it's costly, and our one-size-fits-all trial and error approach is really leaving too many patients without care and therapy that they need. We know that roughly half of those who are prescribed CPAP therapy, if we look at them a year later, they're either not using it at all or they're not using it enough to yield benefit. And we also know, and this is sort of not under debate, that people get their sleep apnea for different reasons. So this is a very heterogeneous disorder, and these endotypes or mechanisms of what's driving the disease is really helping us to not only better understand the pathophysiology, but it's also paving the way for a more targeted precision medicine approach to care. And this is allowing us to develop new targeted therapies and test those therapies. And ultimately, the hope is it will allow us to improve management and care and really treat many more patients than we're able to at the moment with the current system.
So, you taught me something when we were preparing for this, that 70% of people with sleep apnea have one or more non-anatomical cause. Tell me about this.
Look, and that's right. That's some of the research that's evolved that we've done over the last decade or more now. And certainly when I entered the field, the focus was very much on anatomy. And that absolutely remains the main driver of this very common chronic respiratory disorder. But as we've done these studies and very carefully looked at the physiology, we now know that yes, indeed, 70% of people with sleep apnea at least, and in some populations it's even more, they have one or more of these non-anatomical issues or endotypes that's contributing to their sleep apnea. And these are potentially modifiable, and they potentially help explain why people are failing with conventional therapies if we're not addressing those non-anatomical. Because the reality is our current therapies, whether they be CPAP, upper airway surgery, oral appliances, all focused on that anatomy issue. And if you are either having therapeutic improvement on the anatomy, so not all the interventions completely improve the anatomy issue, or if you can't tolerate it due to one of these non-anatomical contributors, such as a low arousal threshold, then this becomes a problem for treatment adherence and ultimately the optimal treatment selection.
So you have developed a way for us to assess our patients a bit better and to help us determine their endotype. So tell me about PALM. What does it stand for?
Look, the PALM scale is really very much the goal is to do that, is to understand on a per patient basis how bad is the patient's anatomy, the patient standing in front of you, as well as those three non-anatomical contributors. So if we break it down, the P in PALM stands for Pcrit, our best functional measure of or assessment of the upper airway collapsibility, or our anatomy surrogate during sleep. So that critical closing pressure of the airway. So that's our P in PALM. The A represents the arousal threshold, or simply how easily you wake up when your airway narrows. So we all get a bit of airway narrowing when we go off to sleep as the muscles around the airway relax, but some people are just very sensitive to that extra negative pressure that we build up when our airway narrows a little bit, and that can contribute to light sleep, cyclical breathing, and ultimately potentially inadequate upper airway muscle activity. So that's the A in PALM. L is loop gain, or it's an engineering term that's used to describe the stability of the respiratory control system. But in practical terms, it just means how sensitive you are to carbon dioxide, which is the main driver of breathing during sleep. And it turns out that some people are just very sensitive to small changes in carbon dioxide. And this can set you up for that sort of typical cyclical pattern of breathing that we see in obstructive sleep apnea. And so it's, again, one of the key disease modifiers of sleep apnea. And then finally, the M in PALM is the muscles. And so how well the muscles respond around the pharyngeal airway. Some people are able to activate their muscles even when they've got a narrow airway. And so this is what's largely driving obese people with narrow airways who do not have sleep apnea. Our studies and others have shown that this is because they've got 3 or 4 times more muscle activity around the pharyngeal dilator muscles during sleep. And of course, the opposite is also true. You can have just a little bit of an anatomical problem, but if your muscles aren't working well, then that can drive and actually cause sleep apnea. So there's the breakdown. About a third of people wake up too easily or have a low arousal threshold. A third have high loop gain or unstable respiratory control, and a third are unable to really generate any meaningful muscle activity during sleep without waking up. And to put those together, it's about 70% of patients have one or more of those problems.
Oh, that's where that number came from. I didn't realize that. Okay.
Yeah.
So, how should I use this when I'm approaching my patient? How does this help me figure out what to do with my patient?
Well, ultimately, what these concepts are proposing are the first step is really to find out how bad is the anatomy of the patient in front of you, and of course we use the Pcrit. And so, we are developing simplified tools to get at that. That's the first thing you want to know. So does the patient in front of you have really bad anatomy? Is it sort of moderate, or is it actually not too bad at all, or what we'd say, pretty good anatomy. So it turns out about 25% of patients have, very collapsible airways, and that is their airways closing above 2 centimeters of positive airway pressure. And so that's a really bad anatomy. They go off to sleep, plus, there's positive pressure in the airway, and that airway is closing again and again. So these are kind of people that are probably going to need CPAP or a major anatomical intervention, whether that be upper airway surgery, oral appliance, or combination thereof, to help with that anatomical issue. So that's the first thing. If it's a bad anatomy, that's giving us some clues there. Most people with sleep apnea, their airways closing at about atmospheric pressure, the Pcrit. And so that's about 60% of patients. And then the other factors really come into it. How bad is those non-anatomical contributors? About a third of people whose airways closing at about atmospheric pressure, they don't have any issues with the other non-anatomical causes. And so you can really have quite a bit of confidence, at least theoretically, that targeting the anatomical problem, and perhaps in those people, we know that oral appliances improve the Pcrit, assuming you can push them far enough forward, by about 5 or 6 centimeters of water. So if you've got a person there with Pcrit that's 0, and you've got an oral appliance and they don't have any non-anatomical issues, that should be a home run for them. So there's another example. And then the final example is that other about 20% of patients who have So it's about 20-25% who have terrible anatomy, about 60% or so that have, moderately collapsible airways. But 1 in 5 people with sleep apnea, their airway is only minimally collapsible. And in fact, their anatomy is exactly the same as people that don't have sleep apnea,
Huh.
or many people that don't. So the airway is closing at suction pressure between -2 and -5 centimeters of water. And in these people, 100% of them, which makes sense, they've got a problem with one or more of those non-anatomical
Right.
issues. So it's that you've only got a minor anatomy issue, and it's interacting with those non-anatomical that's driving it. So theoretically, yes, an anatomical intervention that improves their anatomy will fix this a little bit. Uh, the other one is but alternatively, going after one of the non-anatomical causes should theoretically fix their sleep apnea as well. And that's where things that target the arousal threshold, loop gain, or muscle responsiveness may be in of itself a therapeutic solution for this 20% of patients. So that's the model, that's the idea, and then the goal is really how do we translate that?
Mm-hmm. Well, that's what I'm wondering. I'm sitting here and I'm wondering, how do I, as a clinician without a research facility, how do I figure out what somebody's Pcrit is?
Look, and so here's some examples of how you might go about doing
Mm,
that. So there are some surrogates that we can immediately do from a clinical study. Obviously we are using these in research settings, and we and others are developing simplified estimates of these tools that we can start rolling out. Because I don't think the pathophysiology side, as I've just laid it out, is controversial now. That's well accepted by the field. There's recognition. The
mm,
challenge we have is, as you said, where are we at with these tools that we can use clinically? And there's where the work lies, including the validation and rollout of these tools beyond the research setting. And so what we've got for that is, if we look at Pcrit, so most people, or many people, given that they usually go onto a trial of CPAP pressure, CPAP therapy, I should say, the pressure at which they need to keep that airway open is a good surrogate of how collapsible their airway is. So we've published this in a couple of studies now in different cohorts, and effectively, the greater pressure you need, the more collapsible your airway, and that kind of makes sense. So,
mm-hmm.
and there's actually it's a linear relationship, so you can plug in a number of what their therapeutic CPAP was and get an estimate of what their Pcrit is likely to be. And it's about 70-80% accurate as doing a Pcrit assessment, so pretty good. So there's one thing we could do, whether that's an in-lab therapeutic study or an APAP study. It should give you some idea of the collapsibility. You can also look at the sleep study report. People that are having more apneas in compared to hypopneas as a
I
ratio,
wondered. Yeah.
yeah, they got a more collapsible airway. So that holds true as well. And so, people that are just having hypopneas, their anatomy is not as bad.
Mm,
Whereas, that if that ratio kicks up to more apneas, then it's more collapsible. So that's something you can get from just assessing the sleep state. And that's where people are starting to use this in practical terms, clinicians, when they're looking at the patient in front of them and trying to get some at least estimates based on what we now know about the pathophysiology, how you can, incorporate that into care. There's other things that we're doing. Simple wakefulness tests. Again, this is not yet readily available clinically, but in our lab, we do a 10 or 15-minute test during wakefulness where we provide probes of suction to the airway through a breathing mask, kind of like what you do in a FEV1 test to measure lung function or something like that. It's effectively a breathing test.
mm.
And from that, we can get again about an 80% accurate estimate of the Pcrit just by doing that simple test. So these are some of the innovations that are there now and evolving. And of course, we've got estimates using signal processing, really led by the Boston team, Scott Sange, Andrew Wellman, and others, where you take information from the sleep study, you apply signal processing tools, and you can get an estimate based largely on the flow signal as to how collapsible that airway is.
Oh,
And those,
wow.
yeah, so there's some tools that are, at the moment you need some MATLAB to do that, but those tools are hopefully going to be integrated into commercial systems so that, yeah, you as a clinician can get that estimate in front of you in the same way you get everything, all those other 100 measurements from a sleep study that we get and tend to ignore.
That
Yeah,
we don't pay attention to yet.
yeah,
That we
yeah,
really should be. It's
exactly.
funny. You remind me of a conversation we had with Raj Dedia, who does a lot of Inspire, and he would, during the endoscopy, the sleep endoscopy, would use PAP therapy, and then he kind of had this idea of predicting success if he could splint their airway open with lower PAP settings. And so what you're saying is reminiscent of that, because that was his sort of surrogate for Pcrit.
Exactly. No, and he's used that as you outline in that way, and
Hmm.
that's sort of analogous to that therapeutic CPAP pressure example that we gave. Absolutely.
So are there maybe stereotypical patients that I should think about for each classification?
Yeah, and this is where some of these clinical phenotypes, if you like, so
Mm.
endotypes have been called different things along the way. When we first described these, we called them pathophysiological phenotypes. They've also been called treatable traits. But now, we've landed on the term endotype, and that is the technically correct term that, speaks to, the mechanistic drivers of, in this case, sleep apnea. But if we think about clinical phenotypes, they can be, the things that you look at the patient in front of you. Is this patient obese? Are they male or female? How old are they? Other things like retrognathia, I guess, starts to fit into anatomy and other components. And then you can start to think about symptomatology, how sleepy are they, these other things that might be influential in helping us decide which treatment might be right for this patient. But I guess if we look at the example of obesity, so we know that almost half of the people that are diagnosed with sleep apnea are not obese. And so, it's somewhere in between that 40 to 50% range. And the causes of their sleep apnea, anatomy, unless you do have sort of very prominent retrognathia, for example, typically anatomy is not the main driver of the pathophysiology. At least they've only got mild to moderate collapsible airways on average because they don't have all that adipose tissue around the airway,
Mm.
in the tongue muscles and surrounding tissue that's not physically narrowing off that airway. So the other non-anatomical causes are likely to be much more important. And indeed, that's what we've seen. So in non-obese people with sleep apnea, about 85% of them, instead of a third in the overall population, have that low arousal threshold trait. And so when we look at these people and we follow them up, they do particularly poorly on CPAP therapy. So they physically struggle to wear it. So they physically struggle to take it up in the first place. And when we look at their objective compliance, their numbers are much lower than their obese counterparts. So there's one example of a sort of a clinical phenotype saying, oh, this person's obese or non-obese. Here's some clues as to what might be going on and what we need to kind of think about treatment-wise.
So that's really interesting in that it sounds like you could maybe even make that determination early, at least have an idea of it, and then maybe offer a non-PAP option
Look,
alongside.
exactly, and a non-PAP option. Maybe there's some clues that there's some other things going on. For example, certainly people who also rate highly on the insomnia severity index also tend to have a lower arousal threshold. So there may be some insomnia symptoms going on here and warranting an investigation on that front, because we know that 30 to 40% of people with sleep apnea also have insomnia symptoms, and
Mm-hmm.
things like cognitive behavioral therapy can actually help bring your AHI down, which we think is by non-pharmacologically increasing that arousal threshold. So there's again, or they might need some extra help on PAP to help them through if they are physically struggling to tolerate it, or indeed, as you outline, non-PAP therapies.
So let's take a short break, and when we come back, we'll talk more about OSA endotyping. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apria Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with Dr. Danny Eckert about OSA endotyping and the PALM scale. So, what about nasal obstruction? How does that play into this?
Well, the nose is important for breathing, as it turns out, and
Go figure.
yeah. But we also know in sleep apnea, as people are struggling to breathe, the mouth does come into play. So there's lots of oronasal breathing, or at times just oral breathing, and that can be counterproductive because it can dry out the airway, it can change the surface tension properties. But from earlier experiments where people have actually blocked the nose, you can take a healthy individual and you can give them sleep apnea by blocking their nose. And perhaps, we've all experienced that. People don't have sleep apnea when we've got a cold, we might snore or struggle to breathe. And that's because with the blocked nose, that's the preferred route of breathing. It nicely humidifies the air. But any obstruction you have in the nose can generate greater downstream pressure, and effectively might tip you over your Pcrit for those downstream structures and close that airway, either create snoring or narrowing and closure, depending on the individual's circumstances. So yes, the nose is important.
Didn't James Nestor write that book, Breathe, about that? Where he plugged his nose and developed sleep apnea?
Yeah, look, it was in some of the earlier studies. I remember reading these when I first joined the field 20, 25 years ago, and I thought they were slightly, painful experiments to do in that you're blocking someone's noise. I thought that was kind of cool, but I think they literally just packed the nose with gauze, and that caused the problem. So yeah, we've known about this for a while.
Oh, I didn't realize that's how they did it. I was picturing
Yeah,
tape. It was packed. Oh, that does sound terrible.
yeah, right. But
And you had also mentioned something about trauma from snoring. So trauma to the pharyngeal tissue from snoring.
Look, exactly. That can potentially be a mechanism, or indeed, there's potential for neuropathy of these nerves due to the repetitive hypoxemia, as well as the physical trauma from years of snoring. So there is evidence in people with sleep apnea that there are neurogenic changes that feed the upper airway dilator muscles, which might lead to poor muscle function in at least some people with sleep apnea.
So let's talk about that low arousal threshold. So does that mean that they will have difficulty tolerating any treatment, or does that tell us that maybe some treatment is better tolerated than maybe PAP?
Yeah, look, it is a bit of a sign that that the research is telling us that, yeah, we talked about the PAP example, but it does seem that other examples this also holds true, and it kind of makes sense. So take hypoglossal nerve stimulation that we briefly talked about before. Having a low arousal threshold is a negative predictor of treatment success, and it's probably because they can't tolerate, they're functionally light sleepers, and they can't tolerate enough amplitude that they need to open the airway to get a treatment response. So that's a negative predictor. There is a little bit of evidence that some people with a low arousal threshold may also struggle with oral appliances, although that's less clear. But that requires further investigation to kind of figure out. So, at the moment, probably of those treatments, we're looking at things like surgery and oral appliances as being, the good candidates for people with a low arousal threshold. And of course, we've got these other, if they are obese, the GLP-1 agonists and things are now also coming online, not to mention some of the more experimental drugs trying to activate the muscles and other things that, some of which may also, arousal threshold or may also be an issue for those. Some of them have weight promoting properties, but others do not, such as the sort of potassium channel inhibitors that don't seem to affect the arousal threshold.
So that's interesting. I was thinking about oral appliance therapy, but I hadn't considered surgery.
Yeah. So, because the surgery, it's, if we're talking about, multi-level surgery, that should be an option for them because assuming they're a surgical candidate, because you don't have to worry about the arousal threshold there. You've given an anatomical intervention,
Yeah,
and
that's fair.
if it improves the Pcrit enough below that critical -5 Pcrit level, it seems that if we can get people below that with our interventions, whatever it may be, or combinations, which is the other thing we're starting to look at, that is anatomical and non-anatomical interventions. If we can get them below that -5, they seem to have their sleep disorder breathing resolved.
So if I have somebody with a low arousal threshold, does that mean that I should consider, that we should consider hypnotics?
Look, we've used that in the research setting to try and manipulate that variable from a physiological perspective. And we've done lots of studies to look at what these common sleeping pills do. There was always a fear that these GABAergic agents would relax the muscles and by turning off the arousal mechanisms, we would make the apneas longer and lead to worse oxygen desaturation. We have not seen that in the randomized trials that we've done across a range of common sleeping pills. So they sleeping pills don't seem to make sleep apnea worse per se, and in some individuals they can make it a little better in terms of the AHI without worsening the measure of oxygenation. But the effects have been very modest. And there's other issues, of course, with giving sleeping pills clinically, particularly in the long term. There's concerns and, there's associations with increased falls risks and these other things. So I would say that, having looked at this very carefully over a decade or more now, there's very little, and with some agents, they can have next day, sleepiness and impaired performance. So we just looked at it's used off-label as a sleeping agent sometimes, and that's why we want to look at it. We looked at the antipsychotic quetiapine, and we found that indeed that did, So we found in people with sleep apnea, and here's where we brought this in. Here's the perspective we were coming from. Many people out there with sleep apnea are undiagnosed. And I mentioned that, half or more, 40% or more are non-obese. So they might be arriving at clinic to their primary care, complaining of symptoms of insomnia. We know that these things often go together, and they walk away with a sleeping pill, and yet they've got undiagnosed sleep apnea. There's been more of concern about giving benzodiazepines in primary care, and so clinicians are looking at alternative options. So, it seems that rates of things like quetiapine have been increasing for their sedative properties, trazodone, other things as well. And what we found is, yes, the AHI did go down a little bit with quetiapine, but when we looked at the driving simulator performance and PVT the next morning, they were functionally quite impaired, and there's the downside, and look, that was a single night acute study. Maybe things change long term, but so I don't think there's good evidence for all those reasons to be prescribing hypnotics, but and the reality is the hypnotics that we have don't seem to shift the arousal threshold much for it to be of major therapeutic benefit. But there may be a role in certain people, that also have insomnia issues, in that it doesn't seem to at least worsen their sleep apnea. So, and it can improve sleep efficiency by 10% or more in people with sleep apnea. So there's where we stand with the current evidence on that question.
So maybe a little bit of a silver lining.
Look, yeah, there's still more work to be done to figure this
Mm-hmm.
out. And of course, there are new agents coming on board with these orexin antagonists and things that might, have a better safety profile and potentially shift the arousal threshold more than the GABAergic agents and other things that we've seen so far. But, those studies need to be done.
So do you think ORP might help us with this?
Look, the odds ratio product developed by Magda Yunus is an attempt to get further insight into a dynamic measure of how people or the depth of sleep at any given time, and how quickly they can go back to sleep after an arousal event. And so it's been very helpful on the research front and giving us insights into these components that potentially somewhat analogous to having a low arousal threshold. So there may be some clues in the ORP that help us detect those, and that's where there's been a large push from the field in recent years to develop better metrics and biomarkers beyond the AHI that help us not only work out who's going to respond to certain treatments, but also better disease stratify and risk, to see who might be more prone to things like comesa and other issues. So yeah, I think the ORP can add value. Depending on the question at hand, and again, it's a developing metric that we all need to get our heads around. Literally, yeah.
So is somebody's endotype stable over time?
Look, it is relatively stable if you measure it on 2 nights a week apart. You're under the same conditions. You will get a number that is quite reproducible for things like the anatomy in particular, the respiratory control measure of loop gain, and arousal threshold. The muscles seem to be a little more variable and are a little less defined to date in the ways we've measured those. But there's also been early gold standard studies that have published this quite comprehensively to show things like Pcrit is within an individual under the same circumstances, not only within a night but between nights, quite reproducible. That is within 2 centimeters of water when you measure it on 2 separate occasions. But the disease is not stable, right? Your AHI varies from night to night, and these are the mechanisms that are driving the changes in AHI. So it's not surprising that, yes, they can vary and do, as does the disease. And as over time, things like, your muscle activity may fall off. Your airway gets more floppier as you put on more, or you lose some of those viscoelastic properties with aging. As we put on weight over time, your airway becomes more collapsible. So this is a chronic respiratory disease. These mechanisms or endotypes can change over the time, as does the disease. So it all kind of makes sense. But in the short term, they are stable and more reproducible than the AHI, as it turns out.
What about then addressing loop gain and muscle recovery? Are these things that are modifiable?
Look, they are, and some of the interventions that we've got to date, if we start with the muscles, we've got hypoglossal nerve stimulation, of course, which is targeting the muscles to improve the airway stability. We have emerging drugs that are the noradrenergic agents and other agents such as topical agents such as potassium channel blockers that are really targeted to try and activate the muscles. And then, of course, we've got training, exercises to try and make the muscles less fatigable, which seems to be the sort of primary problem for many people with sleep apnea, as opposed to not being strong enough, because these patients are getting a workout every night, and if you measure the muscles, they're actually quite strong, but they are more fatigable. So there's things, there's some interventions that we have at the moment, either currently in the case of hypoglossal nerve stimulation or training, and there's emerging drugs to activate the muscles. On the loop gain side, oxygen therapy lowers your loop gain, and drugs such as acetazolamide can roughly halve the loop gain issue and also roughly half the AHI. And there are other agents in that a class of drugs that are being tested by Jan Hedner and others over in Europe, and there's been some recent publications in the Blue Journal that are sort of in that class of agents, like acetazolamide, that also lower the loop gain and seem to improve sleep apnea, and seem to also have some blood pressure benefit as well in the initial studies. So yeah, there are emerging agents and targets for those non-anatomical pathophysiological problems.
So I understand that you had a whole day session at ATS discussing this. So tell me about that.
Look, yes. So this, as you know, is a topical issue and one that the field is still trying to get their head around. So we brought a group of experts together. This was under the formal American Thoracic Society research statement proposal that we got up on this topic, and it's all around trying to set a roadmap for the field to do the things that we've talked about in this podcast, which is, what do we need to do to get these promising research tools into the clinic and translate them into better care. So we had a fantastic discussion with from all sides. There's people from all around the planet that gathered there in San Diego to work through this, and we're now working on that statement that we hope to publish in 2025 in the Blue Journal. So we're putting that together now, these consensus statements and roadmaps around what are the research priorities, what are the things that we need to do to roll this out into the clinic to individualize care and make these theoretical approaches into a reality, at least for certain patients who are struggling with conventional approaches.
It sounds like a huge undertaking, but I'm sure it will be very well appreciated and received by the sleep community.
Yeah, look, we're excited to get it out there, and really what we want and need is more people, taking on board these approaches, gathering data, getting more familiar with them, and as we build up that data, it will help us, work out how we can best use these tools and in whom.
So do you have one key takeaway for us today?
Look, I think the recognition, as we've talked about here, that the pathophysiology of sleep apnea is multifactorial. We do need to consider beyond the anatomy what the drivers of this very common disease are, and this can ultimately help us tailor therapy. And what we didn't talk about is combination therapies, which is the other thing that we've just been starting to look at. What do you do with that patient in front of you if they've failed CPAP, you've tried oral appliance therapy, it's helped a little bit, but they've still got some residual disease. Well, we just did a study where we took these people, we fully phenotyped them with gold standard approaches with needles and wires down, catheters down the airway, nearly 100 people. And then if they didn't fully respond to the oral appliance therapy, we took the things that are already available, so your position therapy device, and we were able to treat another 50% of the patients right there just by adding on oral appliance therapy. And then in a research setting, we added things like oxygen therapy to lower the loop gain. We added things like these emerging drugs to activate the muscles. And in fact, and so we held back CPAP as a last resort, and it was very few patients who we were unable to at least lower their AHI on these sort of acute studies below 10 where we needed CPAP. So using these principles, we effectively were able to treat something like 90% of the patients without CPAP therapy with this targeted stepwise combination therapy approach. So look, I think that hopefully that gives patients and clinicians who are excited about opening up the the various treatment options, that there is some hope that these concepts are emerging and that they may indeed have therapeutic potential for many patients that are struggling within the current system.
It sounds very promising to me that you had that much success without even using CPAP.
Look, yeah, exactly. And these were not just patients with mild to moderate disease. These were severe people that you typically wouldn't prescribe an oral appliance therapy necessarily, but we were able to show that in this study, and we've published that, or at least the first part of that study, earlier this year in the Annals of the American Thoracic Society, and presented the larger findings at the ATS meeting earlier this year. So full paper to come next year.
more to come. No, I love hybrid therapy. I love the idea of a little bit of mandibular advancement with maybe some low dose PAP or some positional therapy or something like that to really, personalize it for the person sitting in clinic in front of us, right? Instead of just trying to do a one size fits all.
Look, that it makes sense based on the pathophysiology, and this is where patient preferences can also come into this model that we would ideally like to roll out. Talking through the various options, you can go in and using the data and the physiology knowledge that we gain, we might be able to put some percentage numbers of likely success that would help inform that conversation between the clinician and the patient as to what option they would like. And it may be for a certain patient, they say, look, based on your physiology, you've only got a 20% chance of responding to multi-level surgery, but the patient's like, well, I'm not using any of those other devices. I want to go and do that 20%, and then at least you can go in with some informed physiology knowledge and numbers behind you to help make those decisions. But hopefully there would be other examples that would lead down other pathways where you're likely to get a greater success up front.
Well, and it is so important to have that conversation, right? And to really partner with our patient and hear what they're trying to tell us.
Absolutely. And it's, obviously there's different levels of knowledge, as all these new treatments are starting to emerge, the options are opening up, and it can be difficult to find out about all those options, and particularly for the patient who, this may all be new to them. So these are going to become more important. GLP agonists, other things that are coming online now. Our field is changing.
Very cool. Well, thank you so much for joining us today and helping us better understand the POM classification as well as OSA endotyping.
My pleasure, and sleep well.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.